Hey guys, how are you all? Welcome back to MedSteps YouTube channel. So today in this video we are discussing about very high yield topic and very most commonly we can see in emergency ward, okay, in emergency department. So here today our topic is hip dislocation. So in this video we are discussing about some basic like anatomy and classification and some clinical evaluation and management and some potential complications also we are going to discuss in this video. Okay, so first of all, what is hip dislocation? Hip dislocation is when the femoral head is displaced from the acetabulum. Acetabulum means you can think that is hip socket. Okay, so when that displaced from that femoral head is displaced from the acetabulum, it's a acetabulum, then we can call that is hip dislocation. It's a medical emergency due to risk of neurovascular compromise and avascular necrosis. Okay, so what are the bones includes in this hip dislocation means, first of all we have to go little basics of the pelvis. Okay, this is the first image. If you are seeing this image, you can see here this is anterior hip. In this anterior hip we can see femoral head. This is the femoral head. This femoral head is we call that is ball. Femoral head we can call that is ball, and this inside one socket, like you can see here, that is in inferior part of the pelvis. You can see here one socket. That socket we call acetabulum. This acetabulum is the part of pelvis. Okay, so this both area we call ball and socket joint. Okay, or the hip joint is a ball and socket like synovial joint. Okay, this most of the structure is stabilized by some bones, that is femoral head and acetabulum, and this acetabulum is mostly, if you are seeing this image, you can see here this is acetabulum. This acetabulum is formed by, this is lateral part of the acetabulum. If you are seeing this image, you can see here this is ilium. Sorry, I have to change pen color. Yeah, this one is ilium. Okay, and this part we call ramus, and ischium, and this one pubis. Okay, these three things will form our acetabulum. Okay, so this acetabulum is formed by ilium, ischium and pubis, and this area we can call this is ramus. Okay, so here we can see some if you are seeing this lateral image, you can easily understand this acetabulum is formed by these three parts, and femoral head we called ball, and this thigh bone is called that is femur bone. Okay, so this is sacroiliac joint, and this is the ischium and this iliac crest and this lateral lip and everything. Okay, ASIS and PSIS, everything. When we are discussing about anatomy of the structures, then we will go little deep. Okay, so we can see some ligaments. First of all, this is iliofemoral ligament. If you are seeing this iliofemoral ligament, this ligament is very strong. Okay, this is iliofemoral ligament. If you are seeing this ligament, you can see here we call this is iliofemoral ligament. It's very strongest, and mostly it prevents hyper extension of the hip. Hyperextension. Okay, so this is very important ligament, iliofemoral ligament. And next we can see pubofemoral ligament. This thing will give like stability and support, and you can see some ligament that is ischiofemoral ligament. Okay, we can see this is posterior image of the hip. Then here we can see this is ischiofemoral ligament. Okay, if you are seeing here, we can see ligamentum of teres. This is ligamentum of teres. This ligament is coming from femoral head. Okay, from a femoral head that ligamentum will come, and in this ligamentum contains small artery to femoral head. Okay, so and we can see something, we can see some acetabular so this is the ligamentum of teres. It contains some blood vessels. When we are getting that hip dislocation, then that small arteries and some small arteries will get tear, and it can cause bleeding and neurovascular compromise. Okay, so next, acetabular labrum. If you are seeing this image, this is fibrocartilaginous ring deepens the socket. If you are seeing this image, this is this circle part is giving support to the acetabulum. This thing is we call acetabular labrum because this part is formed by cartilaginous ring. It will help for holding the femoral head. Okay, the femoral head ball, it will help to hold. Next one, we can see some muscles around the hip. Mostly we can see some gluteus, this gluteus minimus, and some iliopsoas muscles and adductors. Okay, and this is adductor brevis, adductor longus and gracilis, these things, and gluteus maximus, gluteus minimus and superior gemellus. This everything attached with femoral head. Okay, this thing will help for adduction. Okay, and some internal rotation, and these things it will help for these muscles. Okay, and some adductors and hamstring muscle and quadriceps. This every muscle is we can see in hip complex. Okay, these are the muscles around the hip. We can see these things. Okay, and here we can see some blood supply, that is because of this hip dislocation, this blood vessels can get stretch or tear. So because of that we can see one condition, that is avascular necrosis. Okay, in avascular necrosis, if you are seeing this image here, you can, if you are seeing, it can cause avascular necrosis. If you are seeing this image, you can see some of the blood vessels. So here, this first of all we have to know the this blood neurovascular setting of this blood vessels. Okay, if you are seeing this image, you can see here medial circumflex femoral artery. This is the main artery for supplying supplying blood circulation to femoral head. Okay, and next we can see some lateral circumflex femoral artery. This is the branch of ascending and ascending. This is the branch of descending branch of lateral circumflex femoral artery, and we can see some of the artery of ligamentum teres, are also known as foveolar artery. This is, we can see, minor in adults. Here, why this thing is important, why I am focusing here mostly means, if any patient got hip dislocation, then it can cause stretch of these arteries or tear these vessels, mostly especially in posterior dislocation, and it's increasing the risk for avascular necrosis. Okay, so that's why I'm mostly focusing in this circulation. Now, hip dislocation, this femoral head displaced from the acetabulum, then we call that is hip dislocation, and we can see some neurovascular compromise and avascular necrosis. Okay, now we are going to discuss about two types of dislocation we have. In that thing, most common dislocation is posterior dislocation. In posterior dislocation, mostly we can see 90% of posterior dislocation, and most common type is posterior dislocation. If you are seeing femoral head is displaced posteriorly, okay, when you are getting this posterior dislocation, then we can see the femoral head is displaced posteriorly, okay. And we can see, if you are seeing this image, you can see here, this is the posterior dislocation image, okay. In that patient we can see this type of image, okay. Here that femoral head, this femoral head moves, back, backward, that means posteriorly like this, okay. And the femoral head lies behind the acetabulum. This is the, here you can see head of the femoris, it's, we can see behind the acetabulum. So what will happen here with this posterior dislocation? What are the things in anatomically, what are the things will happen means, here this posterior dislocation, it can tears capsule and posterior ligaments. When we discussed about ligaments, I mentioned one ligament name in posteriorly, we can see that is ischio femoral ligament can get tear or stretch, okay. Ischio femoral ligament, this ligament will give support to hip, okay. So when we are getting this hip dislocation, then we can see this tear will get tear and the capsule will get tear, and it can compress the sciatica nerve, it can compress sciatica nerve, and we can see this posterior hip joint, it can make cause posterior acetabular, it can cause some fracture. I already mentioned that some fibrocartilage we can see in acetabular labrum, so there we can see some fracture also, okay. Fracture of posterior acetabular rim. So if you are seeing this image, you can see here flexed knee, okay. Focus on this image, we can see flexed knee and adducted and internally rotated and shortened leg. If you are seeing this everything, then we have to think about that is posterior dislocation, okay. So here this is often due to this posterior dislocation mostly happens because of dashboard injuries and our car accidents, okay. Flexed hip posterior force. In clinical features, we can see limb appears shortened, I already saw this image, and flexed, adducted and internally rotated, and we can see that pain, inability to move limb, and may have sciatic nerve injury, and especially we can see peroneal division, okay. Next one, anterior dislocation. In anterior dislocation, 10% of anterior dislocation we can see, and mostly this dislocation happens because of forcefully abduction and external rotation, okay. And here mostly we have to focus on the femoral head that displaced anteriorly, inferiorly and superiorly. If you are seeing this image, you can easily understand little more better, okay. In this anterior dislocation, we can see here, this is in anterior dislocation you can see here that femoral head, okay. That femoral head we can see anteriorly, okay. This femoral head we can see anteriorly and little inferior, okay, or superior. These things we can see in anterior dislocation. The acetabulum is lies in front, okay. So In anatomical effect, mostly in anatomical effect, we can see some things here structurally, that is, we can see some disruption because of this anterior dislocation. We can see some disruption of anterior capsule, and mainly we will get some ligaments problem, that is iliofemoral ligament. That iliofemoral ligament is helps for stability, it will give stability in anterior. Okay, so here because of this anterior dislocation we can see that anterior capsule disruption, and mainly iliofemoral ligament get in some stretch at here. Okay, next we can see some femoral nerve injury, because that this femoral nerve injury in posterior hip dislocation, sciatic nerve injury, these things happens because this nerve is passing very closely to this ball and socket joint, hip joint. Okay, so here this femoral nerve and some vessels get injured because if this displaced medially, because this nerves and vessels passing from medially. Okay, and in anterior dislocation very less likely to injure sciatic nerve, because in posterior dislocation we saw this sciatic nerve. Okay, in limb, if you are seeing this limb, you can see some position, limb position will be like abducted. Okay, see here this leg is going like away, so abducted, and that leg rotated, so externally rotated. Okay, and we can see slightly flexed. So based on patient's limb position, we can easily find out that which type of hip dislocation. Okay, it's very easy, it's not a hard, but we have to think little more. Okay, and we have to go little deep. In femoral head, the displaced anterior, inferior and superior less common, and we can see limb will be abducted, external rotated and slightly flexed, and less common nerve injury, and these things are okay. Here main thing, rarely maybe some that injury will happen, that is obturated nerve injury also, sometimes it can happen. Okay, sometimes simple and complex fractures also we can see, like also with like in complex you can see with acetabular or femoral head fracture and neck fracture, because of this hip dislocation it can cause. Okay, so next, mechanism of injury. In mechanism of injury, I divided into three things. First one, trauma. In trauma we can see high energy injuries like motor vehicle collisions, MVC, or motor vehicle accidents, or falls from height. Okay, these things can cause hip dislocation. And some congenital, like in infants, like development dysplasia of the hip. If you don't know about development dysplasia of hip, I already mentioned I already made one video, so if you are getting time you can see that video. So next, in post surgical also sometimes that hip dislocation will happen, because after total hip replacement surgery, because of the prosthetic dislocation also we can see sometimes. Okay, next, how we can do investigation about hip dislocation. First of all, we have to do X-ray. In X-ray, if we can see sometimes because of dislocation we can see fracture and Seton's line, and sometimes acetabular teardrop, or that some we can see some joint space narrowing, and asymmetry of the hip, and displacement of femoral head from acetabular region, acetabular area. Okay, if I seeing this image, we can see here, because in hip dislocation we can see this in radiographically, the things will help to identify this is anterior dislocation or posterior dislocation, we can easily find out. We have some, okay, this is the things we have to that in hip dislocation we can see asymmetry. Okay, and acetabular will be like teardrop, that acetabular, that joint space will be get narrow, and we can see some asymmetry, and we can see some displacement of femoral head from acetabular region. Okay, in some patients we can see Seton's line also. This is the that femoral head is went to up. So what we have to tell for this femoral head, this thing went up, so this is anterior dislocation, posterior dislocation. In this image you can see that head went up, so that is anterior dislocation. Okay, here that head came down, so this is posterior dislocation. Okay, so with X-ray you can easily find out the hip dislocation. Okay, so first in investigation we have to do X-ray imaging. In X-ray imaging we can compare with this Seton's line also. Okay, you can compare with both sides, and we can do some CT scan. In CT scan we can do like, it's like associated fractures and incongruent reduction. Okay, and if any patient have any vascular necrosis risk or soft tissue injuries or labral damage, then vascular complications, if we are suspecting any soft tissue injury, then we can do MRI scanning. Okay, so next in management, first of all we have to think about reduction to prevent avascular necrosis. Okay, in first we have to do reduction, and we are trying to prevent avascular necrosis, and we are doing pain control with and sedation. We can give some analgesics, and we have to do some neurovascular assessment, and we have to avoid some complications, and we have to follow first of all primary survey. In primary survey we have to do like ABCDE, like airway, like trauma protocols, like airway, breathing, circulation first, and especially in polytrauma, and we have to immobilize the spine if trauma is suspected. Then after we have to expose and assess the limb position and everything. Okay, next in secondary we have to focus on hip assessment. In hip assessment we have to check the limb deformity like shortening and rotation, and we have to assess the pulses, and we have to check the capillary refilling time, and we have to do some neurological exam. In neurological exam, if patient got like posterior dislocation, we have to suspect sciatic nerve injury. So with the sciatic nerve, because of sciatic nerve injury, for neurovascular examination we have to check with the dorsiflexion or plantar flexion or sensation or dorsum of foot. Okay, everything we have to check the sensation and everything. Next is femoral nerve, like anterior dislocation. In anterior dislocation sometimes it's very rare, it can like obturative nerve injury also happens. Okay, in femoral nerve we can check like knee extension and sensation of anterior thigh. Okay, and we can do some manual we have some manual maneuvers or techniques for reduction the dislocation. Okay, so in reduction technique we can start with like within 6 hours we have to minimize the avascular necrosis risk, because first of all we can do the posterior dislocation reduction technique. Here we can see we can do like Ellis maneuver. In Ellis maneuver, this is okay, if you're seeing this image you can see here this is Ellis maneuver. In this Ellis maneuver, if you're seeing this this is very common technique we are using for posterior dislocation. Yeah, we have to keep that patient in supine position, and we have to assist the stabilize the pelvis, and that physician or operator that first of all we have to flex the hip, and we have to flex the hip, and knee will be like 90 degrees, and we have to apply some traction upward, and we have to gently we have to rotate the leg to guide femoral head to back. Okay, so this thing we call Ellis maneuver. Next one we can, if that is Ellis maneuver is not working properly, then we can do Stimson maneuver. Okay, so in Stimson maneuver if you are seeing this image, you can see here the patient will be in prone position, and the hip and knee flexed at the edge of the bed like this. If you can see this image and you can appreciate the thing, and we have to apply some downward pressure on leg, and we can assist with internal rotation. Then we can bring back to the normal location, normal position of the femoral head. Okay, so if this thing is not work properly, then we can do Captain Morgan technique. This is the Captain Morgan technique. If you are seeing this image, you can see here that physician or operator's knee under the patient's knee we have to keep, and that patient will be in supine position, and we have to lift up, we have to do that knee will be like upward lift, and we have to do some, we have to use some little pressure and for energy, and we have to do external and internal rotation. Okay, so this is the things we have to do in posterior dislocation. This is the techniques. When it's coming to anterior dislocation, in anterior dislocation we have to apply some similar traction, but it's like opposite direction, and we have to use same similar rotation techniques, and but direction will be in opposite side. Okay, in note, if unsuccessfully this we tried every technique but it not work properly, then we have to do open surgical reduction, and we have to do immobilization for 2 weeks, and we have to apply some brace support and physiotherapy and rehabilitation. Okay, so here if patient is like coming to you, then first of all you have to decrease the pain, right? How you can decrease the pain? We can start with morphine, like 2 to 5 milligram intravenously every 5 to 10 minutes we can give. It's like emergency, maximum 10 to 15 milligram only we can give, or if morphine is not available, then we can give fentanyl 50 to 100 microgram intravenously and rapid onset. Okay, in sedation we can give we can give midazolam 1 to 2 milligram intravenous slowly, or for sedative we can give propofol like 0.5 to 1 milligram, and we can per kg, and intravenously bolus for procedural sedation, and we can give oxygen support 9 liters per minute and continuous monitoring and airway equipment on standby. Okay, so these are the things we have to follow in management. Next, in indications we have to do some like surgery, like if this every maneuvers techniques everything is failed means, then we have to start with this surgical management. Before surgical management, for reduction we have to start with analgesics like NSAIDs or ibuprofen. We can give 400 to 600 milligram like PO every 6 to 8 hours for 5 to 7 days. This is the drug regimens for reduction. Okay, or we can start with diclofenac like 50 milligram PO BID, or like Panadol like acetaminophen 500 to 1000 milligram every 6 hours. If NSAID is contraindicated, then we can start with acetaminophen, and we can give some opioids like tramadol 50 to 100 milligram PO every 8 hours if like in severe pain, and we can give some muscle relaxants for spasm like diazepam 2 to 5 milligram PO BID or TID for 3 to 5 days. Okay, and we can start some DVT prophylaxis, deep venous thrombolysis prophylaxis, like especially if immobilized patient, then we have to start DVT prophylaxis. We can start with enoxaparin 40 milligram subcutaneously daily like for 7 days, or we can start with rivaroxaban like 10 milligram PO daily for 14 days. Okay, and in indication we can start with in surgical management we can start with failed closed reduction and associated acetabular or femoral fractures and recurrent dislocations, soft tissue interposition, total hip replacement and dislocation needing reviews. Okay, next, in complications, before complications, next we are going to discuss about complications. We can do avascular necrosis, in complication we can see the avascular necrosis of femoral head, because risk of every more than 6 hours means before reduction, then the patient we have to suspect avascular necrosis. Okay, we have for this thing we have to do MRI surveillance, and it may need joint preservation or replacement. Okay, next, post traumatic arthritis. In post traumatic arthritis we can see like NSAIDs, joint injections, and eventual total hip replacement. Okay, next one, like sciatic nerve injury. This sciatic nerve injury mostly we can see like sciatic nerve injury or sciatic nerve palsy. 10 to 20% for that thing we have to do, we have to start physiotherapy, and we have to do some nerve studies also. And in recurrent dislocation we have to do like surgical stabilization, and we can see sometimes heterotrophic ossification. Okay, so after surgery the patient have to do follow-ups like 1 week post reduction, like in first visit, and we have to check the healing and pain control. In subsequent visits we have to like at 6 weeks and 3 months or 6 months and 1 year. Okay, every time when that patient is coming we have to assess the imaging for avascular necrosis or arthritis, and we have to monitor gait and hip range of motion and nerve recovery, and these things we have to check every time. Okay, next, if in physiotherapy, okay, here I already mentioned posterior physiotherapy and rehabilitation. Here if patient like okay, after hip dislocation in week 1 to 2 we have to give to the patient bed rest and pain control and basic passive range of motion, and we have to avoid hip flexion greater than 90 degrees and adduction and internal rotation. In week 2 to 6 weeks then we have to do gradual weight bearing with crunches or walker, and we can begin active assisted range of motion exercises. In week 6 to 12 weeks, then 6 to 12 weeks we can start with full weight bearing and strengthening exercise for gluteus, hip flexors, and quadriceps. Okay, and we have to avoid some high impact activities for at least 3 months. Okay, so these are the things about hip dislocation. We already discussed everything. I already covered everything, like we discussed little anatomy and investigation and mechanism of injury, and we have some types of dislocation, anterior and posterior dislocation, and we discussed some surgical management like and we studied some techniques also, like Alice maneuver, Stimson maneuver, and Captain Morgan techniques, and some complications, and how we can start with rehabilitation. Everything we discussed. If you have any doubt you can ask me in comment section. Like, share and subscribe. We will meet in our next orthopedic lecture. Take care. Bye bye.